let's get started. I want to thank all of you for coming tonight, and I know we'll have some others joining us as well. And special thanks to Dr. Kevin Murphy, who I know spends a lot of time putting these together. They're so thoughtful, and we really appreciate that time. So it's all yours.
Well, thank you. I'm going to show my vaccinated button here, only because all of the unvaccinated people remind me of that joke of the fellow who was in a downpour of rain. It was flooding. The street was filling up. The yard was filling up. And along came an emergency vehicle offering to evacuate him. He said, "No, God will take care of me. I put my trust in God." And after a while, the water rose, and along came a boat. But he said, "No, I trust in God. I know I'll be saved." And so then it got higher, and he was on his roof, and along came a helicopter, and he said, "No, I put my trust in God. I'm going to be saved." And then it went up over his roof, and he drowned. And he arrived in heaven and protested that he'd put his faith in God and hadn't been saved. And God says, "What do you mean I didn't save you? First I sent you a truck, then I sent you a boat, then I sent you a helicopter. What did you want? A winged chariot with angels?" And that's what you got. And so we might reframe that. First I sent you masks, then I sent you social distancing, and I sent you vaccines. What did you want? Well, we'll talk about what we have tonight. And this is a rough outline. I probably won't follow it very faithfully, but we'll certainly talk about the Omicron wave, both its epidemiology and its virology. We'll talk a little bit about how much the vaccines are protecting us, where the monoclonal antibodies have gone, and then new oral antiviral drugs for COVID-19, which are suitable for use in outpatients with mild disease, not yet hospitalized, in an effort to prevent hospitalization. And then now what? So you've all seen graphs like this showing the surge of Omicron cases in the United States at the end of December and into January, vastly exceeding the Delta wave, which we thought was pretty terrible. Our current case counts at the beginning of this month worldwide passed 300 million cases and more than 5.5 million deaths. The U.S. leads in cases with 52 million, ahead of India and Brazil. We also have the highest death count, just ahead of Russia, followed by Poland, India, and Germany. At the beginning of this month, we were at 500,000 cases a day, higher than at any other point in the pandemic. So we might take a lesson from South Africa. That was our earliest experience. Notice how it has replaced the Delta wave, which was tapering off in October in South Africa. And it was a very sharp rise and a very sharp decline. So we are hopeful that we will follow suit in several ways. First of all, that it will only last 4 to 6 weeks as it did in South Africa. And that the deaths will lag behind the cases. This is the South African experience. And the notice in the Omicron case, the deaths down here in black do not rise as nearly as high as they did with the Delta wave. And in fact, the case fatality rate in South Africa fell from 8% to 0.2% between Delta and Omicron. The duration of the Delta wave was 5 months as compared to the 4 to 6 months I just alluded to. The proportions of patients with comorbidities during the Delta wave was very high, 52.5%. And yet during the Omicron wave, only 23%. The median age also fell from 59 during the Delta wave to 32 during the Omicron wave. Outcomes were vastly different. So of those treated in the emergency room in this large group of acute care hospitals in South Africa called Netcare, only 41% were admitted as compared to 69% during the Delta wave. Only 18% required oxygen as compared to 74% during the Delta wave. Less than 2% required mechanical ventilation compared to 12% during Delta. About 19% were admitted to the ICU as compared to almost 30% during Delta. The length of stay was 3 days as compared to 7 or 8 during Delta. And the deaths of those seen in the emergency room totaled a little less than 3% as compared to 29% during Delta. So we seem to be following a somewhat similar pattern now. So this is in the United States, and the Omicron cases are in red. You can see that sharp spike again, and the hospitalizations are in yellow, and you can see that the hospitalization rate is not climbing nearly as sharply as the case rate, and not nearly as sharply as during Delta, that previous wave. All right. This is sort of a visual representation to give you an idea of the relationship between our hospitalizations. These are total hospitalizations. The first 100,000 or so Americans currently in the hospital with COVID-19. So the dark blue are those in the hospital. The light blue are those in intensive care units, and that small white proportion at the bottom is those on a ventilator. So not nearly the proportion that we saw with Delta. However, our hospitals are filling up during this surge, and you'll notice that Nevada is bright red there, meaning that 86 to 90% of our ICU beds are filled with COVID patients. We're not as bad off as Alabama, Missouri, Texas, and New Mexico, where more than 90% of the ICU beds are filled. So this is where we stand as of today. US cases 68 million US deaths, working toward the million or so that Dr. Fauci has predicted. We've had 47,000 just in the last month, 48,000 almost. A national positivity rate of 40.1%. Now we're doing a little bit better in Nevada at 24%, even though our hospitals are bulging. The 66% of the ICU beds in the United States, some 26,644 patients, are occupied with COVID-19. And that's out of 40,000 occupied beds. So we've got 601,682 cases in Nevada so far, with more than 8,000 deaths. Well, the Wall Street Journal published a very interesting argument in an editorial on January 7th, pointing out the sobering fact that the deaths directly due to COVID-19 are not the only deaths we're seeing because of the epidemic. They're pointing out that we have excess deaths from suicide, homicide, overdose, and accidents, all because of the stress and isolation that goes with this pandemic. Some 82,000 excess deaths. Other excess deaths from fear of hospitals, avoidance of hospitals, and delayed procedures on the part of hospitals due to heart disease, lung disease, CVA, cancer, another 86,000. And this is up to August of last summer. And in the months after that, up through the middle of December, additional excess deaths due to these causes were 56,000. So clearly the part of what we're doing in an effort to contain the epidemic is contributing to other kinds of deaths. So now, if the case fatality rate really has dropped to 0.2%, near that of influenza, this highly transmissible Omicron wave may in fact reach enough of the unvaccinated and boost enough of those who are vaccinated to put us near herd immunity and curb the epidemic without lockdowns and allow us to address these other constraints on the economy. An interesting argument. I'm not proposing it or promoting it, but I do think it requires us to think. And so does Dr. Fauci. And in some ways, he says something similar. He thinks that the surge is going to decline by the end of this month, but maybe after peaking at 1 million cases a day. He thinks the pandemic will transition to an endemic phase. He doesn't make it clear whether he thinks that's coming this spring or after other surges from other variants. Nobody knows, so he's not going there. He also, interestingly, predicts that we'll have a vaccine for children under 5 by February. And then he outlines an interesting sequence of epidemic events. He said we're only in the first phase of 5. That's a little intimidating. So we're in the true pandemic stage. That's going to be followed by a deceleration. The third phase is what he calls control, and others have called endemicity. In other words, a level at which there's ongoing low-level transmission, but not enough to disrupt society. We can go on with our lives at last, but not be rid of COVID-19. Then what he calls an elimination phase. It's not clear what we have to do to reach that phase, but he's talking about the kind of regional presence that certain other diseases that we've seen in the United States, like yellow fever, malaria, and so forth, that are no longer here, but are endemic in other regions. One might also think about polio, which has been now limited pretty much to Pakistan and Afghanistan and maybe northern Nigeria, through tremendous efforts to control it through vaccination. And then the final phase is eradication, but we have to keep in mind that that's only been accomplished for smallpox, although we are very close with respect to polio, with neonatal meningitis due to Haemophilus influenzae type B, and the Carter Foundation's activities in West Africa have almost brought dracunculiasis to an end. I don't think this is going to happen with this virus, but there it is. So his bottom line is that we'll have to learn to live with SARS-CoV-2, much like influenza and other respiratory viruses. And he doesn't address the risk that other possibly bat-associated coronaviruses may also emerge and jump to humans and cause other pandemics. Well, where are we with respect to vaccination? Nationwide, 62%. However, gratifyingly, that includes 88% of those over 65. Yet our seroprevalence is only 31% as of Halloween. In Nevada, we're at 57% and 81% of those over 65. In Washoe County, we're at a little better. 62% have had 2 doses, but only 39% have had the booster. 87% of those over 65, however, have had 2 doses, and almost 60% of those over 65 have had their booster. And Clark County is a little behind us. Now, breakthrough infections due to Omicron are clearly a problem, and this is the English data on the subject, and you can see it's much higher than with Delta after 2 doses of the vaccine, especially. But the booster brings it down to that red dot that you see at the right-hand side of the graph, but not as far down as Delta-associated breakthrough infections. So, we still have, however, with the booster, about 75% protection against Omicron, but not that very low level of breakthrough infection rate that we have with, or had with Delta. So here are breakthrough cases of COVID-19 in Nevada in spite of vaccination. But remember, so far, vaccination's only been defined in terms of 2 doses. So there is talk of not calling one vaccinated until the booster dose now. That's talk we wouldn't have had last fall when Delta was the problem, of course. Well, here are the variants by Greek letter, alpha, beta, gamma, delta, and so on. And then all of the other variants that were named, but not nearly as threatening as those first 4. And now at last, Omicron. So you'll see there are 9 letters left in the Greek alphabet. And so the question is, will we have enough Greek letters? And as long as I'm on the subject of Greek, let me say that it is Omicron, not Omicron. Omicron is the name for the short O in Greek. We have another letter, omega, for long O. So omega should be pronounced omega, not omega. And Omicron should be pronounced Omicron, not Omicron. Yeah. A little complaint about the media there. Okay. And then what is the next variant? Well, there's one that's appeared in France in December related to travelers from Cameroon. But it has just been overwhelmed by Omicron and looks like it's just going to disappear in spite of its 25 mutations and 33 deletions, including retaining some intimidating mutations there at the bottom of the screen. So it doesn't look like it's going to rise to the level of variant of concern, and it's probably not going to get a Greek letter. But will there be other variants of concern this spring? We don't know. So what about this Omicron? What's it all about? We'll talk a little about molecular virology here for the next few minutes. And here are the key mutations. And notice as we look down on the top of the spike protein, notice it's a trimer. It's three proteins that are wrapped around each other with their tops pointing out in a triangular fashion. And all those little blue dots are new mutations. The green segments are deletions that also alter the infectivity of the virus. So lots and lots of mutations. Notice too that on the left-hand side, number 4 is the furin cleavage site, and those mutations increase the affinity of Omicron for a human protease called furin that is responsible for amputating the club on the end of the spike protein, and that reveals a fusion protein that allows the viral membrane to fuse with human membranes. And we'll talk about that a little bit more. So this is a comparison of mutations in Delta and mutations in Omicron. And you can see that we're talking about more than 50 mutations in Omicron, 30 of them in the spike protein, 15 of them in the receptor binding domain, and 9 of them in the receptor binding motif within that domain. In other words, directly at the site that binds to the ACE2 receptor. And at least 6 of these markedly enhance binding to the ACE2 receptor. I think we just saw that actually. So let me just remind you a little bit about the cycle of replication of this infection and replication of this virus in order to make a couple of points about how Omicron is a little different. First of all, viral entry, as you all know, occurs by attachment to the ACE2 receptor. But there's also a transmembrane serine protease that helps to facilitate that binding and also to cut the spike protein in a way that allows fusion of the viral membrane with the host cell membrane, and then expel the virus into the cell. Now, we'll talk in a minute about an alternate pathway, but there's also a whole process of engagement with the endoplasmic reticulum, in which the virus transforms the endoplasmic reticulum to form what are called double membrane vesicles, which provide a safe haven for the virus to be replicated and translated. It then passes to the Golgi apparatus where it's assembled. Furin then comes in again to facilitate membrane fusion and then exocytosis, or exit of the cell from the cell. So there are at least two pathways for cell entry. Now, I mentioned that transmembrane serine protease. I don't know why it requires such a long abbreviation, TMPRSS2, but but that's it. And that mediates one style in concert with the ACE2 receptor and furin, in the way I've just suggested to you. But there's another method of cell entry by endocytosis, and that's mediated by cathepsin L. The cathepsins are proteases which have a lot of important functions in the body in terms of activating our own proteins. And so it is also commandeered by this virus to facilitate its own. So this is a diagram to show you how furin decapitates the spike protein, exposing that fusion protein that I mentioned in the stalk. So the club end, the outer end of the spike protein that attaches to the ACE2 and transmembrane serine protease, that's the club. And you can see in that inset at the top the way in which the club is decapitated, exposing the fusion protein and allowing the viral membrane at the top to fuse with the host cell membrane below, and then internalize the virus. This is another mechanism that seems to be particularly important for Omicron. There are on our cell surfaces integrins that offer an alternative pathway for cell entry. And that RGD you see is actually a 3 amino acid motif, arginine, glycine, aspartate, that allows the virus to attach to an integrin, that is the beta chain of the integrin, at the same time that it attaches to the ACE2 receptor. So it does not need the serine protease, the transmembrane serine protease that I mentioned for that mode of entry. This is that 3 amino acid motif. Again, it shows you where it is and the way in which it works and the way in which it's somewhat different from SARS-CoV-1, actually. Well, the change in cell tropism by Omicron accounts for two things. First, why it's milder, and secondly, why it's much, much more transmissible. So just this month, Kelsey Huntington and her group at Brown University showed that Omicron enters upper airway cells, meaning nasal mucosa and bronchial epithelial cells, much more readily than pneumocytes. And they also showed that these integrins are important in mediating that mode of cell entry, so that the integrin inhibitors that are used in cancer chemotherapy, for example, are actually in vitro active against Omicron. Chan and others demonstrated rapid replication of Omicron in cultured explants of human bronchus, in contrast to human lung, and much more rapid replication in bronchus than other variants. Furthermore, Omicron has shifted its cellular tropism away from the TMPRSS2 expressing cells that are enriched in the lower respiratory tract and the GI tract, with obvious altered pathogenesis. Now, one of the things that one might worry about is that activating integrins does activate TGF beta, which is a potential cause for cytokine storm. But that seems not to be happening in Omicron infections. So this is Chan's work showing the preferential replication of Omicron in the upper airway as compared to Delta. So 7 times the replication. Remember, that's a log scale on the left side, showing the tissue culture infectious dose 50. And Omicron is replicating at 7 times greater numbers than Delta, and 10 times less in the lung. So this is simply to show the Omicron switch and cell entry mechanism, shown by Willett and others. The lung cells that are rich in TMPRSS2 support Delta much better than HEK. Those are human embryonic kidney cells, which only support that endocytotic entry that I said that Omicron specializes in. So the A549, which is a lung adenocarcinoma cell, actually supports both pathways. And you can see on the lower panel there that chemistat, which inhibits that transmembrane serine protease, inhibits infection with Delta, but not with Omicron. And conversely, if we inhibit the cathepsins that are important for endocytosis, it inhibits replication of Omicron, but not Delta. So a major change in cell entry mechanism, and I'm going to skip this slide. But the same workers, that is Willett and others, also showed reduced neutralization antibody titers induced by the Pfizer, the Moderna, and the AstraZeneca vaccines against Omicron. So on the left-hand side in blue is the Pfizer vaccine. Notice the drop from the wild type strain as compared to Omicron just to the left of it. The Oxford or AstraZeneca vaccine using the chimpanzee adenovirus vector, it also shows a dramatic reduction, even more severe than the Pfizer vaccine. And then on the right, in brighter yellow, is the Moderna vaccine, and notice that it actually drops a little less than against the other two. So nevertheless, in spite of milder disease, we do have a surge in hospitalizations, and this is the graph for that up through early January, with some 1,711 hospitalizations per day. And we have some new tools for trying to prevent hospitalization in early COVID-19. One is something that we hadn't really noticed before, that is an early study using remdesivir in outpatients. And it's a 3-day course, so 200 milligrams loading, 100 milligrams a day for 2 additional days, so 3 days. And I'll come back to why that might actually be more practical than you'd think. We have sotrovimab. Now, why is sotrovimab important? Well, it's a monoclonal antibody that preserves activity against Omicron, unlike all of the previous authorized monoclonal antibody combinations. There is Lagevrio, which is the brand name for the drug you've heard of as molnupiravir. That's the Merck, well, it's a Merck drug now. It was originally developed by the Emory Investigational Drug Group. And then there's the ritonavir boosted nirmatrelvir, which is Paxlovid. You've heard of that by now. Evusheld, which isn't actually for post-exposure or for mild disease, but it is for immunosuppressed patients who are unable to make antibody in response to vaccine. This is a long-acting monoclonal antibody. That is, its FC portion has been modified in such a way that it hangs around for 5 or 6 months. And so it's basically passive immunity for people who are unable to mount active immunity. Well, there are problems with all 5 of those, mainly availability. So we might actually have to consider an unauthorized drug that has a little traction, and I'll show you the data, and that's the antidepressant fluvoxamine. Now, other antidepressants may have some activity too, but fluvoxamine has the best data behind it. Well, this is the remdesivir study, and you can see it's really pretty impressive in this Kaplan-Meier curve in terms of preventing hospitalization in outpatients. And this is the Gottlieb paper in the New England Journal at the end of December. This is the forest plot, and you can see that with all of these subgroups analyzed, the forest plot shows the the case going to remdesivir over placebo, even in those with major comorbidities or other risk factors. Well, there's reason to want to have new tools, and that is the reduced vaccine efficacy against Omicron. You can see with 2 doses of the mRNA vaccine, the ability of serum from those folks is 127 times lower, or up to 127 times lower, in its ability to neutralize Omicron. Even with the booster, it's 3 to 37 times lower, although that's still in the range to have a fair effect in protecting us from hospitalization, and if hospitalized, from mechanical ventilation and death. So feel glad that you got your booster. What about prior infection plus a booster? Well, it's not as good as 2 doses of the vaccine plus a booster, as you can see. What about Evusheld, which I just mentioned? That double monoclonal antibody, long-lasting for immunosuppressed patients. Well, it is 12 to 30 times lower as compared to its ability to neutralize Delta. So it is still worth giving to our immunosuppressed patients. All right, well, if we look at all of these tools for trying to prevent hospitalization in patients with early COVID-19, here is what we're looking at. So with Paxlovid, the efficacy, the risk reduction is about 88%. Sotrovimab, with its well-preserved activity against Omicron, is a little lower than that. The remdesivir treatment that I mentioned, that is the 3 days of daily infusions, is at 87%. Obviously, molnupiravir is rather disappointing, but still has some value if you can't get anything else, which may be the case sometimes. So there are serious problems with Paxlovid in terms of drug interactions, and that's because of the ritonavir booster. I will show you the long list. I had a patient this week with CLL who had no antibody response after his booster dose, and who indeed has hypogammaglobulinemia. And so we looked at how many of his drugs would have to be stopped, including his cancer chemotherapy drug, in order to take Paxlovid. And it was 5 drugs that were going to have to be stopped. So he might be better off with Sotrovimab. There are no drug interactions. And there's some forgiveness in terms of how soon you have to give it. Within 10 days of onset. Obviously, the earlier you give it, the better. Now, the remdesivir can't be used in renal failure or hepatic failure. Molnupiravir can't be used in pregnancy because it's teratogenic in animals. You don't want to give it to breastfeeding women, and it has deleterious effects on bone, so you don't want to give it to children. So those are the limitations. Well, let's look at Paxlovid. So it's ritonavir boosted near metralavir. Metralavir. Anyway, so the ritonavir is a powerful CYP3A4 inhibitor. Also inhibits the P glycoprotein, important for drug transport across membranes. So that's why it's used. That gets the nirmatrelvir high enough to be effective, so the drug does inhibit a SARS-CoV-2 protease, which is important in the replication of the virus. There is a renal adjustment that's required. We have to reduce the dose of the nirmatrelvir from 300 milligrams twice a day to 150 twice a day. So it comes in a packet that I'll show you, but the pharmacist has to remove one tablet from each dose card in order to accommodate your patients who have GFRs between 30 and 60. The ritonavir dose does not need to change. And it's altogether contraindicated below a GFR of 30. So here's that packaging I was telling you about. So notice that there are two nirmatrelvir tablets in the dose card for dose dose. So one of them on each side of the card is removed by the pharmacist. So you have to let the pharmacist know to do that. Obviously, you will by indicating that the dose is 150 milligrams nirmatrelvir and only 100 milligrams of ritonavir twice a day. But it's a little extra work for the pharmacist. I can just imagine the pharmacist standing there punching the the tablets out of the card, one card at a time. Here are the modes of action of these two oral antiviral drugs, nirmatrelvir and Lagevrio, or molnupiravir. Both of them act internally, not on viral entry. The Pfizer drug, the nirmatrelvir, acts on a protease, which is important in breaking up the polyprotein chains into the individual viral proteins, the non-structural proteins that shut down the cell's metabolism and also make us sick. Molnupiravir, on the other hand, interferes with the polymerase, the viral polymerase. And it does so in a way that's different from remdesivir, which makes me think that it would be very likely synergistic, not only with nirmatrelvir, but also with remdesivir, because it substitutes for the cytosine in the viral polymerase, whereas remdesivir substitutes for the adenosine. So if you can hit the polymerase in both ways, these two drugs might be synergistic. But that theory of mine has not been tested. Well, here are the ritonavir drug interactions that you have to be concerned about with Paxlovid. It increases levels of, and this is not an exhaustive list. These are drugs that I thought you might actually have patients on. That is the more common ones. But it includes amiodarone, amlodipine, bupropion, colchicine, statins, sildenafil, and tadalafil for that matter, steroids, trazodone, and Versed and triazolam. Then there's some special cases. For transplant patients, it elevates to potentially toxic levels tacrolimus, sirolimus, and cyclosporin. This is not a drug you're going to be able to use in transplant patients. Women on birth control are going to lose their birth control if they don't switch to some alternative method. And then clopidogrel, if you're using that one, in patients who've just had a coronary stent, it increases the risk of thrombosis in spite of the clopidogrel because it lowers its effectiveness. And then the chemotherapy drugs that are made more toxic by ritonavir, vinblastine, vincristine, venetoclax, ibrutinib. Let me just talk about the problems with availability before we talk about fluvoxamine. There are only a couple of CVS stores in Reno that have any molnupiravir at all. The one on North Virginia has 40 bottles. There might be and actually, I think DeMonte Ranch may have some, but not very much, and no Paxlovid at all. Walgreens on North Virginia has plenty of molnupiravir, but no Paxlovid. So St. Mary's has 6 vials of the sotrovimab. Renown has 8 vials of the sotrovimab, although they say they're getting daily shipments, so they might have more tomorrow. Northern Nevada actually is the winner here. They have 12 vials of sotrovimab. They also have 10 courses of Paxlovid, which you can't get at the retail pharmacies. And they have more Paxlovid at one of their freestanding emergency rooms in Northwest Reno. Kudos to Northern Nevada. As far as the Evusheld is concerned, Renown Infusion Center is offering it, and I'm not sure what their stock is at the moment. But Evusheld did reduce the risk of symptomatic COVID-19 in their 5,000 patient study from 1% to 0.2%. Whereas, in other words, 1% among the placebo group and 0.2% in the immunocompromised treatment group. The problem is that there are 700,000 doses that the government has obtained and is being distributed for the 7 million immunocompromised patients in the United States who are at risk. So there's a serious problem with availability for all of these new tools. Now you might say, well, remdesivir has been in good supply. On the other hand, at what point, if we're using remdesivir for very many outpatients, are we going to run into difficulty with an adequate supply for our inpatients? So that's an issue potentially as well. So fluvoxamine, on the other hand, is readily available. But it has not been authorized or approved or recommended, for that matter. So I'm going to soft pedal this a little bit, but there is some data that gets one's attention if one is up against not being able to treat patients at risk who have mild or early COVID-19. So this is a study from Croatia. So you might immediately wonder, it's obviously not robust. It was 51 patients with matched controls. It was not randomized, but there was a significant difference in mortality between those who were on fluvoxamine and those who were not. That is 58% versus 76%. So much more robust. And actually, I've shown you this data from Brazil in a previous session. So I'm just reminding you of it. This is the forest plot. This was 5,000 patients. It was a randomized controlled trial, so much more robust than the Croatian trial, obviously. It was published in Lancet Global Health just last October, and so it's been peer reviewed. And you can see that regardless of the subcategory analysis, the forest plot favors fluvoxamine over the placebo. So that deserves continuing attention, I think. There's some other studies that suggest there may be other antidepressants that have the same value, particularly SSRIs in particular. And that may speak to the mechanism that is, serotonin may actually be important in the replication of SARS-CoV-2. So last word is about treatment, because this is an aspect of treatment that's not received a great deal of attention. It has not become standard of care, and perhaps it should. It is actually authorized and recommended, so we shouldn't have too much hesitation. These are Janus kinase inhibitors for hospitalized patients who are at the cusp of a cytokine storm. Now, baricitinib is really the best studied of these, and so that's what I'm going to talk about. Theoretically, tofacitinib should also work, and there is some data to support it, but baricitinib is the one with the most robust data behind it. It interferes with viral cell entry in vitro. It interferes with pro-inflammatory signaling by IL-2, IL-4, IL-6, interferon alpha, beta, and lambda, as well as granulocyte colony stimulating factor and GM-CSF. It does, however, increase the risk of herpes simplex, herpes zoster, URIs, UTIs, and gastroenteritis. It also increases hypercholesterolemia. So in a randomized controlled trial of some 378 patients on high flow oxygen, it reduced mortality from 27% to 17%. That was the COVID barrier study. But steroids were excluded, which does not seem like a good idea, since dexamethasone is standard of care. The ACT-2 study was also a randomized controlled trial of a larger number of patients. And in that case, dexamethasone was not excluded. So baricitinib plus remdesivir and dexamethasone was superior to standard of care alone in patients on high flow oxygen in terms of recovery time and accelerating clinical improvement. I don't have mortality data for you. Now this is a forest plot, and you can see that it favors baricitinib. You might wonder about that inverse probability regression there at the bottom, but actually by that analysis, by that analysis, there was a very significant difference in mortality. Well, that brings us to the end. And for those of us who have managed to escape COVID-19 for 2 years, we wonder how long that's going to last. And I'm reminded, with apologies to my non-Christian friends, of that line from Psalms 91. Fear not the pestilence that stalks in the darkness, nor the plague that destroys at midday. 1,000 may fall at your side, 10,000 at your right side, yet the evil will not come nigh thee. Well, that's only been true for 2 years for some of us, and it may not last as transmissible as Omicron is. So with that, I will conclude with this Bruegel picture of plague deaths, and invite questions and comment and protest.
Thank you. You can put questions in the chat, or you can unmute yourself and ask them.
Okay, I stopped the sharing. Yes. All right. Oh, where is that chat? Okay, I don't see anything in the chat.
I don't either.
I see Dennis Yamamoto though, staring at the screen.
Kevin, thank you very
Yes.
much for doing such a great job. I've learned so much tonight, and my head's spinning here. So it's the old doc and me. You know how that goes. Us Wisconsin people.
Yes.
Hey, just a clarification, Paxlovid is available at Community Health Alliance. I just was notified about
I'm
that.
glad to hear that. Thank you.
I was just notified about that the other day. You know, I'm on the foundation trying to raise money for that clinic, and the clinic's done a
Good.
great job in getting the vaccine out to anybody. And they are doing testing to anybody, and they also have a avenue to Paxlovid that a lot of us don't, and that's through the federal government. Their pharmacies run through the feds, and it's amazing what they can do with their pharmacy that even hospitals in town can't do. It's just incredibly crazy how that whole thing works. But they do have some dosing, and they really hold the protocol, as you had mentioned, the 3 to 5 days of symptoms and the exhaustive list of meds that you cannot take. It's incredible.
Mhm.
So it's not something you just order, sent to the pharmacy. The pharmacist will go crazy in town. So just to let you know, it is available there. They've been doing a great job there. And thank you very much, Kevin, as always.
Yes. Well, yeah, thanks for pointing that out, Denny. There's a separate distribution path to the federally supported health centers, and obviously that's what the Community Health Alliance has taken advantage of, and I'm glad to hear it worked. Good. Right.
We have a question in the chat from Brad Graves asking, are 4th boosters coming for anyone after 5 months from the 3rd?
That's an interesting question, and the immunocompromised might represent a different category.
Mhm.
A longer wait might represent a different situation as well. But the Israeli study, which was started fairly early with 4th doses in patients at very high risk, primarily immunocompromised patients and healthcare workers. In both of those categories, there was only a slight increase of antibody titer as compared to a 3rd dose or booster dose. And there was only a little diminution in the rate of symptomatic disease. Now, they have not reported hospitalization, ICU admission, mechanical ventilation, and death in that study yet. So perhaps you could argue that not all of the data is in, but it was a little discouraging. Now it is true, however, that there is in the works new monoclonal antibodies that are specifically for and new vaccines that are specifically for the Omicron variant. So the problem is the time it will take to get those through phase 3 trials and into arms. It's going to be many, many months. So it could, the surge is going to be over before we have those vaccines, but they may be useful in the endemic phase. So we'll just have to wait and see. So Brad, I hope I answered your question.
Dr. Fredericks?
Yeah. Kevin, did you get the data that I sent you on the dapagliflozin trial?
No, I don't.
I thought I sent you a whole package of information about the DARE-19 trial and that it showed 20% reduction in morbidity and mortality, but was slightly underpowered to reach statistical significance from a frequentist point of view. And I think that's holding up from a metabolic point of view of saying that that is an effective way to try to reduce morbidity and mortality. But those trials are hard to duplicate and expand the ends once you've completed them. So, but you never got that? I thought I sent that to you after the last meeting.
Well,
I can send it again.
Maybe it's my failure to scan my email box assiduously, but I have not seen that, but I'm very interested. So
I'll send it again. I've got it
okay.
on my
Good, thank you.
screen.
Bob, your hair is even longer than the last time.
My hairdresser is in the supply chain problems. That's it. But I kind of want to see how long it'll grow. I'm now kind of interested to see.
Well, I'm interested too. I can't wait till the next time.
Yeah. So I was curious. You made the comments about serotonin, but the serotonin reuptake inhibitors would be increasing the serotonin exposure as a means of protection, rather than mediating the effect. At least you would presume that from its known action. And that those have all sorts of actions even in bone. The serotonin uptake, serotonin suppresses osteoblasts, and it could well be that this is a signal coming from the osteoblasts that are regulating the mortality and morbidity that account for why serotonin reuptake inhibitors would have a favorable effect. I think it fits in with some models. So that finding I think is very interesting as well.
Yeah, the molecular biologists think there are theoretically multiple points of inhibition in the viral cell cycle. Well, we'll have to see.
Is there any evidence that it could be that it is mediated by serotonin?
At least part of its effect seems to be mediated by serotonin. Yeah.
Okay, thanks.
We've got another follow-up from Brad. He's asking, since vaccines, I'm thinking vacation, laugh. Since vaccines are compared against unvaccinated, don't we expect efficacy to drop as more unvaccinated survive COVID? And he also has sent us a graph. Let me pull that up too here.
Oh, can you do that? Oh, yeah, okay.
That's showing the CDC daily trends in deaths. As of yesterday.
Yeah, we think that cases are beginning to drop in North America. That is US and Canada for sure, and in Europe. and with it the deaths, of course. They are still rising in Africa, in Asia, and in Latin America. But yeah, I think maybe the South African experience will be repeated here. So we think this might be over by February. We'll see, or at least down to those low levels that you see for June on that graph Brad so kindly provided us.
Okay. Stop sharing that.
Yeah.
Ricardo Garcia has said, would Dr. Murphy share his email to allow questions online?
Sure. Of course, then I'm sure to miss Bob Frederick's emails if I get blasted, but sure.
And I think he's asking after this session is over. He doesn't say that, but is that the case, Ricardo? Would you respond back to me? In the meantime, we'll hang on a minute here.
Let's see.
Yeah, he met. Yes, he did. He met offline. So.
Oh, really? Okay. Well, that's all right. I think there's no one here who's not a friend. So.
Okay. I'll share
so
that.
Here it is in the chat box.
Okay.
I think I got it right.
Yes. Yes,
Okay.
you have it right.
All right. Yeah,
I have it memorized.
it's too long, but so I always have trouble typing it. But
Right.
let's see. Brad
Looking-
Graves wants to know if we've definitely proven ivermectin does not work. Yes, in fact, the problem with ivermectin is, though, it is active in vitro, but at concentrations that are not safely achievable in people. So if we use doses much larger than are used in the treatment of human parasitic infections, then yes, it might stop the COVID-19, but kill the patient. So that's the problem with ivermectin, I'm afraid. And you've all heard of the emergency room admissions for people with ivermectin poisoning. Yes, don't take the horse drug in the horse doses. Let's see.
we haven't addressed Jason Hill yet.
Yes, vaccinated and prior infections were excluded from the Paxlovid EUA. You know, my own view is that vaccinated folks were probably at an advantage, so it might have reduced the apparent effect, but obviously the mechanism of action of immunity is completely different from the mechanism of action of Paxlovid. So I would expect that immunity plus Paxlovid would be synergistic, or at least additive. Let's see.
I don't see anything else we haven't addressed at the moment.
Anyone else want to unmute and communicate?
Kevin, Denny again.
Yes.
The prevalence of different variants is made, understand, through the sewage system, correct?
Well, that's one way of identifying the presence of the virus in the community.
Right.
Yes, but we know that at this point, 98% to 99% of the cases in the United States by large volume sampling are Omicron now.
So we've had this done before, but this brings up lots of questions when I see patients or people in general. If we do the stool testing, is the virus viable in the stool?
Oh, that's interesting. Well, we know there's plenty of viral RNA in the stool. How much of it is replication competent? I do not know. I have not seen. Haven't seen data on that, I don't think. But that's a good question. Is stool infective? So, certainly in the case of SARS-CoV-1, we know that there was a significant outbreak in the Metropole Hotel in Hong Kong that was related to toilet aerosols. And the problem that the plumbing was such that there was transfer of stool from one room to another through the plumbing, and infection through aerosols from the toilets. So,
Lovely.
yeah. So theoretically, the same thing could happen with SARS-CoV-2.
Thanks.
Other questions? Elaine, I see you're here. You've been quiet. Any comments?
She's not talking.
I guess not.
Okay. Well, Kevin, I sent you the folder that's titled DARE 19 that I had, so it should be in your inbox.
Okay, DARE 19.
It's the
All
DARE
right.
19 folder, and it gives both perspectives, the frequentist and the Bayesian analysis of the study.
Okay, very
They
good.
come to different conclusions, and it's sort of interesting to see how that comes about. Okay.
Good, thank you.
Brad's back with us. He says, at Renown, we're debating whether remdesivir is useful after the inflammatory stage has occurred.
Well, it's certainly going to be less useful because I assume by the inflammatory phase you mean the cytokine storm, and that's a phase in the infection when the viral load is actually dropping off, and obviously pathogenetic mechanisms are set in motion that are going to continue in the absence of the virus, so you could say that it's less useful. Whether it's marginally useful, of course, is open to question. Some would say that remdesivir is marginally useful under the best of circumstances, but it's been the best antiviral that we've had. I think we need to start looking at potential synergism or additive effect with additional antiviral therapies, some of which I've suggested here tonight. Now, of course, that carries with it additional potential toxicity and other problems, especially in patients with renal failure and hepatic failure and so on.
Okay.
Okay. Any other questions? All right.
Well, thank you all for attending tonight. We will do this again when we think it's necessary. In the meantime, if there's other topics you would like to have this kind of a discussion about with your colleagues, send them to me and send me who you think the content expert is. Because these are not difficult to do. For me, they're difficult for our presenters because they have a lot of work to do to get them ready. So again, thank you very much, Kevin.
Yeah,